It is 11 a.m. Pacific Standard Time. I'm Ashley Meyer with PreventConnect, and I'm welcoming you all to today's first session of the Peer Learning Forum, Why is Sexual and Domestic Violence Prevention Central to Population Health? I want to ask you all to please go ahead and mute your lines yourself. You can do that via the mute button that you may have on your phone, and if you don't have one on your phone, you can use *6, and if you press once it will mute you. If you press it again it will unmute you. So we hope that you all participate today, which we will describe coming up as we talk about PreventConnect and what the sessions really are about. So again, I'm Ashley Meyer with PreventConnect. You can learn all about, and I know you know all about PreventConnect through PreventConnect.org. We are an online community of practice focused on the prevention of sexual, domestic, dating, and related forms of violence. We have a lot of different ways to participate and build community with each other. We have an e-learning Moodle-based site. We have a wiki. We have all sorts of social media that I'm circling right now, a blog, and many other offerings. A little bit about the technology. I recognize so many of you that I know you know how to use the technology, but I am going to ask you to go ahead and to raise your hand so we'll see how many folks are aware of this technology. So you just click the My Status hand button right to the right above my picture that you see in the left corner. A lot of directions there, but up on the left side of the screen right next to the phone number, right around here, you will have a hand button. If you could click that for me, I would appreciate it. I see a few hands raised. So that is a place that you can indicate you have a question, you'd like to make a comment, and we use that quite a bit in the peer learning forums because these are very conversational and we have a lot of interaction going on. So I am going to lower all your hands. I do encourage you to continue to use that to get our attention so we know that you have a question or a comment. We do of course have
Ashley?
Yes.
Ashley, I'm sorry to interrupt. In the text chat there are some questions about passcodes for calling in. Looks like Sierra said the passcode wasn't working for her, and Michelle said she didn't get a passcode. Could you address that?
Yes, that is interesting. The email that you got from iLink should have put a passcode in there, and Prevention Institute, I believe that's Alexis, has just put in the passcode. So hopefully folks that are saying that will be able to use that. It's 879736. So I hope everybody is able to get on to the audio, and thank you Prevention Institute for posting that for folks. And David has posted that as well. So you can see the value of the text chat right there. We'll be sharing information, links, but we really, really hope that you all communicate with each other and us through the text chat as well. And there's private chat. Sometimes you want to have a side conversation or share some email or other type of contact information with other folks who you are working with and who you meet on here, and we do hope that you use private chat. It is up on the right side of your screen. It's a gray tab right under the chat. You can just click private and choose with whom you'd like to talk. PowerPoint slides. I am hoping you're all seeing the PowerPoint slides. We've checked with several attendees already who are saying yes. If you're having any issues with those, please just go ahead and type into the text chat that you're having any issue, and we, as you can see, have some fabulous folks with us helping with any text or any tech issues. And I will post very shortly the link to the PDF version of those PowerPoint slides. Oh, I'm hearing, yeah, sounds like I'm going to have to mute all lines.
All guests have been muted. You can unmute your line by pressing *6.
Okay, so all lines have been muted. So what that means is to unmute yourself, you need to press *6. Please use that liberally today. We do not want you to be muted. We're only trying to eliminate background noise. So *6 will unmute your lines. And presenters, you could go star 6 now just to make sure you're unmuted as well. And we will remind you of that throughout today. So that deals with the phone. We will have some polling questions. We're probably going to do more feedback questions. So when those come up, we will be showing you how to use those. We do have closed captioning from our fabulous partners at Aberdeen Captioning, wonderful partners we've had for a long time. So we thank you, Aberdeen. And as usual, we never have to worry about these guidelines in our peer learning forums. These are forums that are a smaller, more limited group of colleagues who are involved in RPE and Delta-focused programs. And we have great conversations, but we always want to remind you to please do stick to the general guidelines that we, for example, provide when we do trainings to our constituents for respectful communication. You can private message me or any other members of the team for help if you're having any issues with tech, but this is a small group, so if you put it in the public chat, we will be able to help you as well. And also there's always iLink technical support for any issues, so this is a good number to make sure that you have. Also have a caption that I will be able to give you to if you need that as well. PreventConnect is a national project of the California Coalition Against Sexual Assault. We're sponsored by the U.S. Centers for Disease Control and Prevention, and the views and information provided in this web conference do not necessarily represent the official views of the U.S. government, the CDC, or CalCASA. And PreventConnect is really focused on a lot of issues that have to do with violence prevention. And today's issue is one in particular that we're going to be talking about. We're really talking about connecting to other forms of violence and oppression, connecting movements, really making connections, but also connecting to each other. And that's what we do today. We've had really great experiences doing this. Many of you who I see and welcome, and thank you for joining us today on this first session, are a reason for that great connection that we have, and we really look forward to continuing that trend today. We do have some members of our team here as well who are, we have Dina Fulton, if I can, Dina's picture, there we go. Dina is here as well. She's going to be participating with all of you, and Abby, and they work together on California's RPE program. And we also have David Lee, who is here as well, of course, the founding member of PreventConnect. David's been with PreventConnect for its whole 10 years, so I just wanted to point out that they are here as well, and you will be likely hearing from them. And I think we'll get started. So why is sexual and domestic violence prevention central to population health? Is what we'll be talking about today. And Annie and Lisa, do you want to go ahead and jump in here? Both Annie Lyles and Lisa Parks are with Prevention Institute. They are our partners on peer learning forums and web conferences, which are standalone. Today is a session of 3, as I know from recognizing all of your names that you're all familiar with. Annie and Lisa and I have all known each other in various capacities throughout the years, and we continue to work together on preventing sexual and domestic violence. So I'm very happy that you're both here with us today. Hello, Annie and Lisa.
Hi. Let's see. I need to have the floor in order to move the slides forward. There we go.
I was clicking on you and it switched to David, so sorry about that.
That happens all the time. Lisa, are you there? Lisa, I think you're on mute because I see your mouse moving, but there is no sound. You need to push *6 on your phone to unmute. It's a good reminder to all of those in the audience. We're going to be calling on you to speak today. So when you are ready to speak, remember to push *6.
Hi.
There she is, Lisa.
Mute myself, but now I'm unmuted. Hi, everyone. I'm so thrilled to be a part of the conversation today. It's Lisa Parks.
There she is. So we had a little technical difficulty getting Lisa logged in today. So she's here with us, but her picture isn't quite up yet. So there she is. You know her. You've heard of her. Her reputation precedes her. But this is Lisa and I, and we're going to co-present with you. This is a 3-part forum. We're so glad you're able to join us. And the objectives are for all 3 parts. So it's a much more organic kind of function today. We'll kind of see where we want to go and how we want to get there. But we will be looking at health issues relevant to your existing efforts. We are going to be talking about challenges and solutions. We're going to be talking about very specific tools, and we're going to be looking at joint strategies. So it's that combination I always love at PreventConnect of, you know, kind of the big thinking, the big problem solving, but also very concrete next steps and tools to get there. All right, so hopefully you're in the right place. A big thank you to our web techs and our prep with Casey and Alexis. I think Alexis is on the line if you want to say hi, Alexis.
Hi, everyone.
Yay, she's been working madly, and as you put questions in, she can help you out with those in the text chat. And to start us off today, we wanted to ask you, what is one gift that you bring to this work? So a lot of the time we're very much focused on tools and approaches and strategies, as I mentioned, and I wanted to just kind of have a moment today as we begin and think about our own unique contributions and the gifts that we bring to the work we do. And I'd love for you to use the text chat. This is humble brag time. And put in one gift that you bring to the work. And I will be going over to the text chat to keep an eye on it. All right, so Sierra got us started off. Thanks, Sierra. Uber enthusiasm. Well, of course, you're the first one. Thanks, Sierra.
We know you all bring gifts.
Yes. So, and you know, my background is MSW, so I'm very comfortable sitting quietly in silence while you all think of an appropriate gift. But we have 33 people on the line, so I'd like to see at least 33 answers, and I know Deb is there with that, so they'll have to put in 2 answers. But it looks like we're starting to get some answers in there. So, Lisa, have you seen any of these yet?
Yes. Humor, love of community, ability to communicate to different audiences, bringing people together.
I love it.
Patience. This is like not only great as individual gifts, but what a great combination.
Well, and Phyllis brings up patience, and of course Abby is there with skepticism. 2 things that I don't probably have enough of, so those would be good partners for me.
Yeah, it's humor, which I don't have a lot of, so that's really helpful.
I love it. Sarah brings up dedication, Matt, humor and interesting perspective. Oh, did you see Deborah? We do all bring the thinking.
This is Ashley. I particularly appreciate both Deborah, the chocolate chip cookies, and also David says bad puns and jokes as well. So just have to verify that for everyone. But really, it is looking like we're a group of folks who really, really are committed to community. As David talks about bringing people together, others have talked about commitment to community. So it's a great room to be in.
Oh, cool. Well, the point of this, because there is a point to it, not just our humble brag and pointing out who it is you need on your coalition to balance out your personality, is really thinking about kind of the core elements of doing this work. And, you know, it doesn't really matter what approach you're using, if it's public health or anti-oppression or whatever it is, but that we all have very specific gifts that we bring to this work. And those gifts really transcend the approach and really help us transition between approaches and transition the language. And actually, I've seen you putting self-awareness as part of it, and we're still working on puns. And I think that kind of reflects some of the conversations that we've had on PreventConnect, which is, you know, we're all very dedicated. That's why we're here. That's why you all stepped aside from whatever you were doing to be here today. and we want to have fun while we're here. And that doesn't mean we aren't critical thinkers that, are exploring tough topics. So in a nutshell, that's what we'll be doing for the next time together. So our topic is about public health and this public health approach. And what does that exactly mean when we're thinking about sexual and domestic violence? It was interesting. We have a group of folks that we've asked to kind of prepare some comments. We want all of you to be able to speak, but we did ask a small group to prepare some comments. And one of the things that Nancy shared with me, Nancy Greenman, and I saw you're on here, Nancy. She's the Prevention Program Coordinator at the Attorney General's Sexual Assault Task Force out in Oregon. And in her comments, she mentioned the criminal justice approach. And it made me laugh because I thought, I've been here long enough that I'm not even thinking about the criminal justice approach yet. I'm thinking about how public health might link to feminism or might link to Black Lives Matters and health equity, and yet we still have some work to do clearly in thinking about criminal justice, and yet we've also gone beyond that. And so Nancy points out that the public health approach opens prevention to everyone, that we all have a role in supporting healthy interactions, relationships, and sexuality. And my starting point for understanding this is the World Health Organization document that you see there. And it was funded through CDC. And if you have folks that are new, folks that are, coming up to speed on this, this is where I always point people. I think it's very well done. It's very thoughtful. It has data for data people. But it also kind of tells the stories that need to be told, and it has a nice kind of credibility with the World Health Organization and CDC behind it. And I'm glad you all like puns and have a good sense of humor, because I also wanted to include this as we get started today. It says, "Are your dolls having a party?" And the daughter responds, "No, Mom, they're revolting against an oppressive government that is trying to remove their civil rights." It makes me laugh every time I read it.
I love it, Annie.
It's like my dream of what my daughter would respond rather than, "They're getting ready to marry the prince," So, I've still got time. I'm working with her. But I think one of the things that we bring to this field, of course, is that public health also has, other approaches for sexual and domestic violence, including feminism, right, and understanding what that approach looks like and what it contributes. And then I have this cartoon for you. The subject of tonight's discussion, why are there no women on this panel? So I really like jokes. I don't tell jokes very well. I should have deployed this to someone else. The subject of tonight's discussion is, why are there no women on this panel? So I know you're all on mute, but I hope you're laughing at your desk or cringing, whatever feels perfect. But I put this one up there because, sometimes this doesn't really happen in the field of feminism, but in the field of public health, there are certainly panels that look like this at times. And even more than that, one of the things that struck me when I was looking at this was, the caption could have been, "Why are there no people of color on this panel?" And that is something that I think as a group of practitioners, we're still thinking through as well, is how is it when we're, thinking about this lens of feminism and gender equity, we're also kind of thinking of intersectionality and making sure that representation doesn't just mean women have been included, but we're thinking about ableism and heterosexism. And even after the last web conference, for those of you that were on, folks cued me to not make a distinction that was purely male and female, and that to think about all the work that's being done in transgender and make sure my comments reflect that in the field. And I was like, yes, you're right. That was binary of me. So there's a lot of ways I think that we can take this work further. So as we talk today, I don't want this to be public health versus feminism. This isn't even public health versus, anti-oppression. This is really thinking about how sexual and domestic violence is a health issue and how that helps us bridge to other places. So, my little picture moved over. Well, okay. Well, this blocks it. So can you raise your hand for me if you're familiar with this model? This is from the collective impact work by FSG, another consulting group. And let's see, we've only got one person familiar with collective impact. I don't believe it. We've got two. So one of the most, I think, intriguing things about the collective impact work, and if you haven't read it, it's worth looking at. It really talks about collaboration. There's a link there in the bottom of your screen. They say, there's several types of problems. Baking a cake where you have a recipe gives the same result every time. Like plus or minus, if you have a recipe, you can probably make a cake. It may not be that pretty, but you'll get a cake out of it. The second thing is more complicated, right? So sending a rocket to the moon. Same thing, though. You need a formula. You need experience. You will sort it out. But once you get that formula, you're pretty much guaranteed, the rocket is probably going to take off. You'll get there. It's just more complex. And then the third thing they have is raising a child. And they have this little, cherubic boy blowing bubbles. And I replaced it with my daughter, Sophie, and her, I'm being compliant, but I'm not impressed with you, Mom. Look. And that's my husband there holding her hand. And the point they make is that in some problems, you can't do the same thing every time and expect the same result. Different people need, and different problems need different solutions. And that one solution that works for a while may not work forever. And I think that's one of the real challenges with sexual and domestic violence is folks come to us expecting to bake a cake or even sending a rocket to the moon. That's really not the way violence works. And if you take a straight health trajectory, like you got exposed to measles and now you have measles, and so we're going to give you a vaccine to prevent measles, what's the vaccine? It's not going to be the same for everyone. And in fact, there are lots of things that work. And so I wanted to kind of bring this to the front and say, we're going to sit in the complexity of this today and figure out what that might look like. So let's get to it. Lisa, you want to start us off here with our poll?
Sure. We have yes, can you hear me? Okay. We have a polling question to get a sense of who's in the room and, again, the gifts that we all bring. So if you could answer this question, for how many years have you been doing the work? And the work meaning working to prevent sexual and domestic violence and other related forms of violence. So A is 1 to 2 years, B 3 to 5 years, C 6 to 10 years, D 11 or more years. So please go ahead and respond to that poll, which should be, I believe, in the bottom left hand of your screen. Is that right?
Yes. And Ashley, I'm not seeing the pie chart.
Oh, you're not? Okay. I am seeing that. So let me go ahead and see if, are you seeing it now?
Yes, I am.
Okay,
yeah.
Great.
Looks
wow.
like quite a mix.
Okay. Yes, it's quite a mix. And so it looks like, give me a minute here, I'm rusty on my math. Oh, did it just change? Okay.
Yeah, so, it changes live as people type in. So if you haven't typed in yet, that's what's really cool about the pie chart is it moves as we go. So if you haven't clicked in your answer on the bottom left, get it in here.
Okay, so it hasn't moved in a sec, couple seconds. So about a quarter of the folks have been doing the work for 1 to 2 years. And then there's a good chunk, almost 15%, that are doing 3 to 5 years. We have another quarter that have been doing the work for 6 to 10 years. And we have 36% of folks who have been doing this work for more than 10 years. That's just tremendous. That's a lot of years. Let's honor that and really bring that into the conversation today, because I think we can learn so much from hearing from the experiences of people who have been doing this work, whether it be for 11 years or more, or the fresh eyes of someone who has been doing it for 1 or 2 or 3 to 5. So I want to ask you to go ahead in your text chat, and if you are willing by phone, if you could unmute yourself and let us know, just give us a perspective from in your experience, especially maybe at this point in the conversation, if you've been doing this work for 6 years or more, if you're in the C or D category, What kinds of changes have you seen in the way that the work has been approached over the last 10 years or more? What kinds of observations or comments can you share to help us be grounded in the history and the progression and the evolution of this work that we've been seeing? So please
and
go
Lisa,
ahead.
Yeah, there's some questions about what exactly that means in the text chat.
Yeah, so I think, let's not worry too much about the exact definitions here of in the field or the work, but thinking about these issues, let's just say it that way. But Nancy, I know you're on. Do you want to kind of share your experience? I know that you fall into our WISE group D here, and maybe you could share a little bit about your perspective. You need to push *6 to unmute your phone. And if others want to chime in to kind of how the perspective has changed, you could raise your hand and we'll cue you up after Nancy.
So am I off mute? I did my start.
Yes.
Woo-hoo.
Bravo. Thanks, Nancy.
I have not been in public health for more than 11 years, but I've been doing the work for many more than 11 years. And I have to say, I don't want to, be Debbie Downer in this, because I'm not. And I was the one who said I love community, and I have had the most fabulous experiences my whole life with communities really knowing what they need and really being able to articulate it and come together to work for it. But, that picture of the guys in their panel discussion, I have to say that that's probably, the most enduring image of being in place after place and room after room where people find ways not to acknowledge that resources are inequitably distributed and do something about it. That I feel that if those of us, and I think all of us, work with communities who understand who controls resources, and I don't know that I've seen much of a change in the ability to shift those resources. Does that make sense?
Yeah, I mean, what I hear you saying is we've had this dynamic for a while, and now folks are talking about the dynamic a little bit more. But the actual shift in resources, it reminds me, David, cover your ears. My Joe Biden speech, I'm still obsessed with Joe Biden's speech at the Futures Conference 2 months ago now. But his closing comment was, show me your budget. I'm messing it up. It's if you can say you care about women, but show me you care. And to show me you care, show me your budget. I'm paraphrasing now. But if you ask me, I actually have the actual quote, and I can give it to you. But that's I feel like where you're pushing, and it's interesting that the dialogue is getting there, but we're in that contemplation stage where we haven't seen as much change. I think Phyllis also makes a comment to that end. And Phyllis, do you want to open up your phone line? And she talked a little bit about how our definitions have changed about primary prevention. Phyllis, are you there?
I would love to hear, from Phyllis. She has a lot to say, and there are a couple folks who are also commenting about the public health approach kind of starting to seep in and the language and getting on the same page. But Phyllis, are you there?
You have to push *6, Phyllis, in order for it to work. Oh, she's only on chat. All right. Next time.
Well, how about Deborah? Deborah had a lot to say as well.
Yes, and I think Deborah is actually going to be our next speaker here in a second. So, Deborah, we'll get you warmed up and have you speak.
Yeah, hi, I'm here, but I can wait. If you want to go ahead and bring other people on, that would be great.
Oh, cool. Okay. I just want to acknowledge Helene's comment, our good friends over in Honolulu, about the progression of working across programs. And I don't know all of those acronyms, but DV, certainly SV, home visiting, And folks are realizing the connectedness of this public health issues, and the feds are moving that way too, which is great. This is great.
And Abby made a comment about creating a newism, or no, not a newism, I'm sorry, but our own ism of professionalism, which creates barriers to getting entry in this work, which to me just speaks to that resource issue and the access issues that are pretty deep and enduring.
Yeah. Well, cool. I mean, I think these are the types of things we like to bring up here, the things that don't have easy answers, things that aren't necessarily, 4 steps. They always joke at CDC, if we only had the right poster, if we only had the right message, we'd be able to prevent sexual and domestic violence. And that kind of goes back to my question on this slide about, this isn't about baking a cake. We're working in something that has quite a bit more complexity, but it also has quite a bit more answers. We have learned a lot in the last years about public health and the health impacts with sexual and domestic violence. So we wanted to just briefly kind of touch on those and then turn it over to you all in the audience to talk about some of those tools. And Deb and Beth in Ohio will start that conversation off when we get there. But Lisa, could you kind of talk a little bit about, how Prevention Institute has kind of thought about the health impacts for sexual domestic violence?
Yeah, great. So folks have been talking about public health and its influence on the work. And on this slide, it's just kind of in a nutshell, when we think about public health, that it's focused on prevention and population-based and reducing risk and increasing resilience. And I think one thing in the last 10 years is that public health has really contributed to quantifying the impact of sexual and domestic violence on health. And so we wanted to share a couple of the tools that we've developed that really articulate this. This first one is looking at the links between violence and mental health. And the next one is looking at the links between violence and physical health or chronic disease. And we have been able to document these linkages, and in this case, really how violence really gets in the way. It really has an impact on people's eating and activity, and it is also a barrier to our public health work in trying to promote healthy eating and activity initiatives, for example, to prevent diabetes. And so what we try to articulate is that violence.
Lisa,
yeah, go ahead. Yeah.
Let me jump in really quick. Sorry, I tried to jump in at the pause and I was muted. I worked on this paper, and this was something that really was an aha for me, was that not only is violence a health issue, like it makes you sick and it hurts you, but it actually gets in the way of all those other health issues. And so I feel like it really changed the way I talk to health practitioners, because all of a sudden I wasn't just saying, hey, let me into the table. This is a health issue. It hurts health. I was saying, look, if you want to be successful in doing your diabetes work, look, if you want to be successful, in doing your physical fitness work, you have to pay attention to the impacts of violence, because it goes all the way back to ACEs again, where you're not going to get there if folks have unresolved trauma, if they are afraid to go outside, if they have these fears. And this document was a real aha for me about how it's not just about the health impact, but how violence really changes your ability to be healthy in so many ways.
Annie, these documents is actually for me in the world I was in at the time, which was I was actually at UC San Diego training pediatricians about family violence, community health. That they were really revolutionary. This was something that folks had wanted to talk about, but they really hadn't seen it kind of made official the way that you all at PI did with these documents. So I really think it kind of set the stage for where we are now.
Yeah.
So we wanted to share those tools and that we think help to make the case, and then ask you about the tools that you think help make the case. And I think, Anne, you're going to...
Yeah. Well, and Mark and Phyllis are already bringing up ACEs, and I know, Deborah, that was something that you had kind of talked about, that, the ACE study is helpful, but it has some limitations. Can you talk a little bit about how that's worked out for you all in Ohio? And I should do a more formal introduction, pardon me. So Deborah Seltzer is on with Beth. And Beth, you're going to have to tell us how to pronounce your name. And they are working at the State Coalition in Ohio. So thanks, Deborah and Beth, and welcome.
Thanks, Amy. And we're actually at the Health Department, and we also have Maggie on the line from the Ohio Alliance. So wonderful to have Ohio so well represented. And yeah, we have Sandra Ortega, our evaluator, is also on the line. So jump in, Sandra, if you would like. And yeah, the ACE study, as a couple of people have already said, has been really helpful, and we've had really great conversations here within the health department about it and brought it to people's attention, and people are interested. But the limitation piece for me is then what? Very recently, one of our colleagues did some really amazing research with regards to in Appalachia here in Ohio and smoking, the incredibly, frighteningly high rates of domestic violence that correlate with smoking and also with cancer. And we were at a conference yesterday where we were talking with someone from the Appalachian community, sharing that information, and I could just see in her eyes, this is amazing information and something I need to know, but what do I do with it? And that's the part where I'm feeling like we have a lot of work still to do, is what is our ask really? So, we share this information, we learn that there are these intersections, but I don't think we've really figured out how to use that to figure out what we're asking for from our colleagues in public health whose fields are also affected. But what is it that means for them? What does that mean for us? What are the shared messages? How do we work together to make a difference around that, as opposed to just learning about it?
Yeah. And I think, another example that Sierra put in was the Search Institute's 40 developmental assets. Again, it's focused on the individual. They actually have some that I think are interesting that focus a little bit beyond the individual, but the ask is never there, or the ask isn't always very clear, and the policy implications not so much sometimes. So it's really, I think it's an interesting question. And Beth, I know you had some experience with ODE, which I'm guessing is Ohio Department of Education, on the passage of a state law. Yeah? Oh, good. The passage of a state law on teen dating violence, and also with the Clery Act and Campus Save. And I was wondering if you could talk about kind of how, as you're starting to do policy work with education, how have you talked about health, and what kind of tools have you used?
Well, in Ohio, I'm like remembering. I can't remember. We got our foot in the door. We wanted to be on this. It's called the Anti-Harassment, Intimidation, and Bullying Bill, and they added teen dating violence to the law, and it was sort of our foot in the door. We've been wanting to work with the Department of Education, and so the passage of the law allowed us to enter the room, I guess. And I guess that would be similar to and so I'm thinking back when the Clery Act changed again, not the present one, but the previous one, that again was our foot into the door with the Board of Regents to begin to address sexual and intimate partner violence on campus and stalking. So I mean, what we've brought to the table is that I think the public health approach, because the public health approach has allowed us to have a model. Like we continually, like, you need a team, a group around the table, making sure that people are in partnership, building trust, and database. We're really trying to be data driven, and what is best practices out in the field, so we can make recommendations. Ohio cannot mandate anything because we're under a home rule, but we can make some policy recommendations on best practices. So I think that the public health model, I'm not getting long-winded, the public health model has allowed us a framework to do our work. So once we get through the door, Deb and I, it's not just me, Deb and I begin our framework of bringing it as it's sort of implementing the public health model in these different places.
Yeah. Well, and I think what you're pointing to is the tools that help make the case. Some of them are actual, approaches, but some of it is really process. And again, one of the things I appreciate with PreventConnect is that we are focused on process. It's not so much sometimes what you say, but how you develop the relationship to deliver a message. And Abby points out that sometimes the ask isn't in the best interest of the askee, like when you ask someone to relinquish structural power. And way to hit for there, or swing for the fences there, Abby, because I think that is hard, and that's not always where we start, but there's some tools to really get things started. And I see Dina's putting in some reports on the financial impact and a little bit more on general sexual violence. She's putting some links in there along with, where did the other one go? Sierra's list of really good resources. And I haven't seen the health impact pyramid, so I'm going to be sure to check that out.
I was going to say one more thing. The one thing that we've learned with the Department of Education folks is that we follow, which I think is a very interesting model. They have a emergency preparedness model for schools, and prevention is a piece of it. But it's sort of I think that thinking about how we look at crisis intervention and recovery, they have that model, and it kind of fits. It kind of fits. So we still get our prevention piece into it, but then when people ask about crisis intervention and recovery, that's part of their model. So I'm just, that's another model we might think about.
Oh, that is. And Noelle brings up another one where you line up the prevalence rates of gender violence along with rates for health issues like diabetes, heart disease, depression. And Noelle, if you skip to the end of the slides, which no one should do right now, we have a really cool example of that. So I think it's an interesting thing to bring up, that this isn't just about health and it isn't just about power structure, but how we're kind of floating between these things, right? So we have one that gets to a little bit of that here. And Prevention Institute, we're all about thinking about behavior and environment. And this is a pie chart I've been using that, I think makes the message really easy. And you already know I'm a fan of pie charts. So it's not just because I'm pregnant and eating pie every day. I do like pie charts all the time. Factors influencing health. We've got genetics, behavior and environment, and healthcare. Drum roll, please. Which of ones is most impactful for health, behavior, and environment? And so we use this a lot of time when I think about healthcare audiences and health audiences that are focused on care and clinical services, which are important, and yet there's certainly an imbalance in terms of budget and investment, back to Nancy's point and some of your points about, where are we investing and how important it is to invest in behavior and environment. Public health knows how to do that. Sexual and domestic prevention folks, we know what to do in behaviors and environment. We may not have all the exact steps down, but we know how to approach that issue. And if you're not working in behavior and environment and you're only investing in medical care, you're really missing an opportunity for health. So this is one of the pie charts we use. And then the other, quote we use a lot is that living in high-stress environments, especially for children, there's this big focus right now on children and trauma, is a prescription for serious behavior problems, physical illness, school performance problems, and there's good data that you cannot significantly improve health status by just providing health care. And I think that's one of the ways we've tried to tailor our audience, our tools a little bit for a health audience, is use some of their language and some of their work, but also translate it back to sexual and domestic violence. sometimes with health folks, there's still like, maybe we could do a brochure. Maybe there's a poster that'll help us out. And, of course, with this field, we know that this is a lot more than going beyond brochures. And what Lisa and I have done is we kind of had this brainstorm with Ashley and with a couple other folks to think about what those bridges might be. So if we want to go beyond brochures, if we want to go beyond the conversation that domestic violence impacts health and you're not going to be successful in your diabetes prevention program unless you take into consider violence, what are the bridges to other issues that really health allows us to cross and to think about? So we came up with 4 bridges. It's not to be an extensive, exhaustive list, but 4 for us to talk about today. And Lisa really helped think about this in terms of the evolution a little bit of the field. And again, this is all kind of fuzzy, but we started with shared risk and protective factors. We've kind of moved to social determinants of health and health equity. And I feel like now where we're sitting is really what are those joint strategies and outcomes that get us there. So what we thought we'd do today is go through a couple of these and get your experiences, get your critique, what works. And I see Ashley's asking for a bridge fund, which I love that idea. And how we could go about this. And the first one is a tool we published with Centers for Disease Control and Prevention last year. How many of you were on one of those web conferences? And if you were on, if you could unmute your line and let us know. CDC had, I think, we used 6 web conferences on this tool. So I imagine a few of you may have joined us. What do you remember about
raise your hand, too.
You can raise your hand, but what struck you? I'd love to have someone open up. If you could open up your line and tell us a little bit about how you use this tool or what you thought of that concept. And then you need to push *6 to open up your phone line.
This is Deborah. I don't mean to be monopolizing the conversation, but we're using it very much. We're crosswalking the kind of tables at the end with our work. Yeah, exactly. We're kind of lining up to say what work do we do more at the individual level, but we'd like to do it later on with the outer levels of the spectrum of prevention, because CDC is asking us to say what are we doing to address specific risk and protective factors. So we're actually using this exact chart to kind of create a matrix that we'll be using with our local programs to say that.
Yeah. And it sounds like, Noelle, you were on some of those, and you hosted the, hopefully you didn't host the authors, you hosted them with your Delta coordinators. What did you think of the tool? Why were you so supportive of it? You can push *6 and it'll unmute you. Are you coming, Noelle? Oh, she's only on chat. All right. So, yeah, I mean, I think this was a really interesting document, and one of the things that got me excited was that you, again, have the stamp of CDC credibility on it, and that it's not just me thinking that societal income and inequalities is an issue, but they've linked it back to IPV, and of course, there's some limitations there, but that just because there isn't any research doesn't mean it's not effective. But there's a lot of places you can start, and we're not going to go through the document, but you can see all the different places. TDV is teen dating violence, IPV is interpersonal violence, SV is sexual violence, all the different places that there's overlap. And I added some yellow boxes here to highlight, but you can see with the other forms of violence there's there. So as we start thinking about risk and protective factors, and most of you have thought about this for a while and have been doing this for quite a while, where do you think you go with risk protective factors? I think, Deborah, you just said, you're starting more at the individual level, and Nancy, again, out in Oregon, said, they provide a roadmap and shared kind of language and vision, even when folks are working on different things. And Betsy in Pennsylvania said that, it's resulted in people thinking creatively about how to access different populations. But what I'd love to do while folks are kind of thinking through that is, Colleen, if you and Marie could open up your lines in Indiana, and we'd love to hear you talk a little bit about your theory of change, and kind of some of the activities you've done, including the infamous neti spaghetti, which other people mentioned, and local hospitals as well. So Colleen, if you all can open up your line, that would be great. Are you there?
I am here.
I don't hear you. There you go. Okay.
Great. Is Marie here?
All right. Well, hopefully Marie will be able to join us. Go ahead and start us off, though.
Okay. Well, in making, there it is, the theory of change. So in making sense of, here, I'll let Marie have my phone.
Hi, this is Marie. So with our, sorry, I'm going to turn my cell phone off so I can not hear myself twice. So we wanted to really figure out what would it take to end domestic violence. And so we started at the top of this poster with what we were calling our ultimate goal of all relationships are equitable and nonviolent. And we started working backwards from there. So we made the green level and then the yellow and the orange all the way down to the purple and the grays. And we were struck by the fact that as we kept going back and back and back, it seemed that structural determinants were really at the root of all of these different boxes here. And so that really helped us make the case to partners who deal with things that typically haven't been associated with domestic violence. So you can't see these little boxes there, what they say, but some of them say having healthy food and having a roof over your head, things like that. So trying to get the other people. The picture we're seeing now, this was a meeting of our local RPE grantees and talking through the theory of change with them. So that showed us what risk factors and what structural determinants are there in needing to be addressed to end domestic violence. And then our neti spaghetti activity is something that my colleagues at Delta Focus were kind enough to participate in this a few weeks ago at the CDC. And this is what I call a working model of a network map. The picture you see here, each of the people standing represent a different social problem. And all of the pieces of yarn represent a risk factor for those social problems. And so one by one, people pick up their strings and they are able to look around and say, wow, me, let's say the man in red, he was representing obesity. He can see that he has risk factors in common with domestic violence and gang violence and school absenteeism, that sort of thing. And we've used this to help people see the connections and how messy it actually is. So that's kind of the point of neti spaghetti, is to show that we really are all connected one to another with various public health and social problems.
Yeah, and I think folks really responded to this activity. A couple of people actually mentioned it as something that they were interested in learning more about. You know, after you make those connections, you know, the question sometimes can be, what next? And one of the things I noticed is that you actually had a joint project with a local hospital with newborn dads. Could one of you speak to that example and kind of how that connects back to neti spaghetti?
Yes, Colleen will speak to that now.
I'm sorry, we had some trouble with our technology in Indiana, so I didn't get the question. Could I have that again?
Sure. I was just saying that once you make those connections with neti spaghetti, the question is, you know, how do you build on that in joint strategies? And you guys shared a really cool example with a local hospital and some policies around dads.
Right. So we did the neti spaghetti activity with one of our local Delta communities, and then after they saw the risk and protective factors that were associated with intimate partner violence and other social problems, we talked through a decision-making tree around risk and protective factors and asked the community to really identify which of these are rising to the top for us as most pertinent, relevant, available, urgent. And the community chose to really focus on childhood-related conditions and child maltreatment prevention. So we've been working with the community through a number of different organizations to identify opportunities in policies and practices and procedures to promote safe, stable, nurturing relationships and environments for all community members. And we try to think creatively about how we can do that with really different organizations and also across the lifespan. And so it made sense to us to start as early as we could. So we worked with a local hospital to promote and institutionalize the practice of promoting skin-to-skin contact between fathers or male caregivers and their newborn infants. And our thinking around this, based on literature review of studies, mostly they're international, is that this practice is a powerful nurturing introduction to parenthood. So by doing that, we feel like we are increasing parental connectedness, which is a protective factor for a whole range of social problems. Increasing connections between dads and their infants, studies show that that increases dads' sense of their ability to provide care for their infants. And we think if dads are feeling better able to do that work, they'll probably be more connected as parents with their children across their childhood. And we feel like if dads are more involved and better connected, that will reduce parental stress for the primary caregiver, who is typically mamas. But also we feel like because fathers have reported that becoming a dad is a kind of a transformative experience, that it also creates an opportunity for dads to think about masculinity through the context of fatherhood in new ways. So thinking about being a father, not just being about being a provider, but being a very nurturing, very physical presence. So starting very early, very young, to foster supported connections between dads and their infants, being a protective factor for child maltreatment, but also teen dating abuse, youth violence, and ultimately adult domestic and sexual violence.
Yeah, and I think it goes back to some of those norms. You've taken it all the way full circle to really challenge kind of those narrow definitions of masculinity, and you've got systems involved, and there's policy involved. I mean, you sent me 2 sentences about the summary, and I was like, yes, like this is it. This is so cool. So thank you so much for sharing. And I'm looking at the time, so I want to keep us moving and turn it over to Lisa to talk a little bit about social determinants of health.
Sure. And yeah, I have to say I love that example, and I think what a great way to show the interconnections of things. I wanted to cover another one of the bridges that some of you might be using in your work. It sounds like Indiana folks are using the structural and social determinants of health in your work, and I imagine others are as well, but we wanted to just talk briefly about this framework as a tool to make the case for sexual and domestic violence as essential to population health. And when we talk about social determinants of health, we are talking about the conditions in which people are born, in which they grow and live and work and age, that influence their opportunities for a healthy, productive life. And I love this language because it's so accessible. You know, it's the conditions where you're born and where you live and where you carry out your life, and we all want that to be a healthy, productive one and a safe one. But that these circumstances are shaped by access to money, power, and resources at the global, national, and local levels. And so these social determinants of health contribute to health inequities, which are the unfair and avoidable differences in health status seen within and between countries and between communities and individuals. So this is the pretty complicated looking, although it didn't look quite as complicated as Indiana's theory of change. But I'm all for
Indiana's didn't even fit on the PowerPoint. We're going to have to get copies of you guys for it because it's fantastic. But
I love it. Yeah, So this comes from CDC, and basically, you know, it shows the interconnections between the social and political context of a person's life, which are everything from governance and macroeconomic policies and norms, and how that shapes social position, how that shapes material circumstances, and how that shapes the distribution of health and well-being within communities. And on the next slide, you may have seen this if you have attended a presentation by Marilyn Metzler from CDC. This is some work in progress on mapping the structural and social determinants of health to the issue of intimate partner violence. And one thing that I really like about this mapping is that if you look on the right-hand side, it really spells out that it's the unequal education funding, unequal mortgage lending, unequal hiring processes, unequal justice system, etc., that are really creating these inequalities in social and economic position and living and working conditions. And of course, there's some interaction between these different levels as well. But it really starts to point at some of these factors and how they specifically play out for intimate partner violence. On the next slide is an example of how Prevention Institute has tried to simplify that in presenting the relationship between the environment and health and safety. And not only does the environment directly shape our health and safety through what exposures we encounter in the environment, but also the environment shapes our behavior, and that behavior shapes our health and safety. So this is another bridge, or this is another tool that can be used to help to make the case, and we'd love to hear your thoughts about how that, if you've used that tool in your work, and the pros and cons of that type of approach. And then Annie also has another specific text chat to share with you.
Yeah, and this was me starting to maybe get a little out of control late at night and fit everything I'm interested in one small text chat bubble. But, we'll get to that in a second. Before we do, I was hoping that Matt could open up his line, Matt Huffman. He sent me a little note, and what you did, Matt, was really, I think, start with this understanding of social norms and thinking about this, that you have to know who lives in your community. You have to think about those social norms, and that social determinants are tied through all of this. So maybe you could kind of share a little bit about your perspective and how you think researching social determinants of health and incorporating them into community-centered prevention strategies is beneficial. Are you there, Matt? I saw you here earlier, so if you aren't, you could touch star 6.
Yeah, Annie, it looks to me like maybe he got kicked out of the session. He was having a little bit of tech issues. So
all right.
Might have
well,
let
me just I can channel Matthew because I do have his comment. I have his comment here, and what he said is, that in order to define this problem of sexual and domestic violence, that you have to know who lives in your community and what the populations are, who's maybe underrepresented in the power structure, and with that, then you kind of investigate the social norms within those communities and in the broader communities, identifying the risk and protective factors. And what I liked about his answer is there's this progression of figuring out who's there, what their experiences are, how that ties to risk and protective factors, and just understanding that, and this is his words, simply living in the same city or town doesn't mean that everyone experiences violence in the same manner, that there's a recognition of cultural considerations in itself, which can be a protective factor, and that universal policies or prevention strategies don't always take into account a margin to center approach. And it leaves, populations within a community more vulnerable. And that's really, to him, the power of looking through these social determinants of health, is making sure that everyone is benefiting from this prevention work and really paying specific attention to it. Betsy, I know that you had some thoughts as well, and Betsy is over at PCAR. Betsy, are you there? You talked a little bit about trauma-informed approaches and how that kind of linked back in. You want to open up your phone line, Betsy, if you're there? Star 6.
Okay, here I am.
Hey, welcome.
Hi, thank you. I wasn't quite sure if that would work, but it did. So yeah, I was just kind of talking about the switch from asking what's wrong with you to now asking what happened to you, and that it can kind of help us look at the whole person, because typically if one person has experienced one kind of victimization, they've probably experienced more than that. So that kind of helps to get at intersection and what's going on with everybody, or what might be all the issues going on with one person, and kind of getting a sense of the whole. I think that was what I was thinking about.
Yeah, and I think that sense of wholeness and kind of cueing environment, even when you're thinking about individuals, is one of those things that has evolved over time, and that social determinants has helped with. And Deborah, I see you have a comment in there. Do you want to open up your line and share really quick about the worry that you have?
Yeah, I just sometimes I'm sitting in a room where we're talking about social determinants of health, and I do very much see it as a helpful entry, and it has brought attention and conversation, but there's also an energy around the true radical social justice approach, which I think gets lost sometimes when we try to, that it can be avoiding the actual experience of people sometimes.
Yeah.
And we could gain a lot from I feel like the public health world isn't always open to the actual lived experience of how this is affecting people's daily lives, with the grit that comes along with that demands a real change as opposed to marginal change.
I think it's really valuable and important, and I think one thing that I like about the social determinants of health is that it can point to, I think as Annie was talking about, a more holistic approach to looking at all the different conditions that are shaping people's lives. But yeah, we don't want it to become so sort of jargony and have a sense that it's not even about human beings anymore. But yeah, I mean, I like talking about social determinants in accessible ways, like talking about these are the conditions of people's lives. This is where people are growing up. This is where families are raising children, and the schools that they're going to and the conditions that they're working in that really create inequality in our communities, and that's not fair, and that's avoidable. So I think that's a really good point, that we need to not become sort of technical and removed, but we're really talking about people's lives and caring about them.
Yeah, that actually is a nice, I was about to say a nice bridge to our next bridge. Yeah, talk about bad puns. I don't even think that's a pun. But let's transition to health equity, because I think that's a little bit about kind of what I wanted to talk about of it, is a little bit about where we're going. And when we talk about health equity here, we start with this premise that violence damages well-being, and it could be physical, sexual, reproductive, the list goes on. And I also like to include violates basic human rights. I think that there's something about that. But that health equity works in direct response to those isms that are sometimes determining how vulnerable people are to the violence, whether it's classism or heterosexism, ableism. And it's kind of how we bring that ism conversation to public health, is thinking about health equity. And it's the attainment of the highest level of health for all people. It requires valuing everyone equally with a focus on ongoing efforts. And, my short answer is it means that we don't always offer everyone the same thing. We're focused on making sure everyone has the same outcome, which is health. And for folks getting to, an experience of life that is focused on equity and respect, it's going to take different things because they've experienced different things and are exposed to different things in their environment. And so one of the things I think that public health is thinking about, and our field has been really thinking about, is this concept of intersectionality. So the idea that violence is one thing people experience, and that sexism is, sometimes a lot of it is at the root of this. but that it's much bigger and much broader. And I know one person here, Nancy, has been thinking about this a lot and even prepared or working on a paper. And so, Nancy, I wanted to open up the line for you and let you share a little bit about how you all are thinking about it in Oregon and even importantly, how you came to those conclusions. And one of the things that struck me in your comments, Nancy, is as you get ready to speak, is that you said that, our prevention efforts are most effective when they begin by addressing oppression, and that implicit in our approach is to look at communities and let them take the lead at each step of the public health approach. When the problem is defined, when when you're identifying risk protective factors, when you're identifying strategies to build protection, and that part of this is really the process of doing that public health approach, making sure community is at the center of that. Even when there's some challenges, in teaching anti-oppression frameworks, for example, maybe in schools, right? So I just wanted to give you a chance to share kind of your thinking, because I know you've been thinking about that for a while.
I have. Can you hear me?
You are on, loud and clear.
Woohoo! Okay, so to start, where I really want to start, and somebody made a comment about this, is healthy relationships, education, et cetera, and that we find the experience, and I'm guessing it's shared pretty widely, when we work with youth, when the programs that I support work with youth, the lessons, the discussions on oppression are the key to opening the key to development, the key to empowerment. Youth really relate, or people say they really like it when we do the oppression pieces of a curriculum, and yet that's also the place where frequently pushback comes from systems, from schools, from parents, et cetera, et cetera. Not all parents, certain administrators get nervous. And so we in Oregon begin by saying that oppression is the root cause of sexual violence. So once we start there, we look at oppression as a risk factor, right? And then we would look at health equity as a protective factor. So it fits perfectly if you want to use public health language. And I think I began by talking about actual experience in the field because we see how that resonates when we communicate with audiences. Does that make sense?
Yeah.
And the other thing I'll say that goes back to my first comment is I think communities understand this. And I think that the language of public health may just be a language, and that there's a common understanding underneath it. And I'm guessing that many of us on this call have experienced that commonality in communication and how powerful it is when we move beyond the specific terms and constructs to the fundamental experience that communities have had of oppression. And that going back to connecting the dots, that's how we've found that document to be so useful. It's a visual to show, to talk about where does violence fit in to what communities know and experience, right?
It does. And what I love, maybe Colleen, if you and Marie could get on deck here, I think they took exactly what you're saying, Nancy, and in their comments to me added a little bit more because they said, within this movement where it's important to name the violence, sometimes that felt strategically incoherent, and that they talked about the term healthy relationships as well being a little bit problematic. And Colleen and Marie, maybe you could talk about
your experiences there and kind of where you've landed with strategies and
Yeah, this is Colleen. And, when I responded to this question, I kind of indicated that this wasn't a question we had asked ourselves directly before, so my response is probably going to be a little bumbling, but we acknowledge that when we first started working with a public health approach, it felt like an awkward fit because we had worked so hard in the movement to ask people to name the violence, to acknowledge the violence, and then moving from that to this healthy relationship framework. There were days when I would say, how is that different from a Carefree gum ad? Like, what is that adding? And it felt like it was masking accountability that we had worked so hard for. So that felt very problematic. But I think as we began to implement the public health model, we recognized that by focusing on naming the violence, we were really kind of locking our analysis in at the individual level. And in doing that, we were kind of allowing ourselves not to see the cultural contexts of inequity that made perpetration more likely for some of us and victimization more likely for some of us. So it felt better to think about the cultural conditions, to recognize the cultural conditions, to think more broadly in terms of oppression than just sexism in our construct. And also we recognized that if we were thinking about the behavior in terms of hitting and violence at the individual level, we were also leaving many of us out of solutions because we could disconnect from that if we weren't personally exercising violence or experiencing it. It didn't have to be our problem. But if we understood the issue contextually in terms of inequity, we've all got something on that. We're all either implicated through our benefits or the ways in which we are limited through the cultural context. So it felt both very strategic and ethically correct to think in that way.
Yeah, I appreciate the progression of your thinking in that, and like the problem-solving aspect of it. It's a tough thing, and Noelle points to some of the challenges there. I know Ashley has written extensively on some of the tensions and challenges. We're leaving many of us out of the solution, expanding the boundaries. I think that's what's great about this audience here is that we are comfortable pushing ourselves and pushing our colleagues and being those champions inside public health and with other groups, thinking about this as a health issue. And we did the strategic plan for Marin, the Department of Health, on sexual and domestic violence. I guess this one was domestic violence. And, folks, we're using the public health model and the shared risk protective factors. And the longtime provider in Marin at one point said, all of these factors are fine, but if we're not talking about power and control and oppression, then I don't know how you're going to get to the bottom of this. She's like, I'm unconvinced. And it was one of those moments where I think everyone in the room had an aha moment that we couldn't just do the public health piece without acknowledging some of the power and control and anti-oppression work that needed to go hand in hand. So I think that's a tension that we all sit with, and I encourage you to keep kind of texting that in, and Mark, that's the patriarchy. And one of the things that we always just include is that, there has to be a deliberate intention to address health equity. And without that deliberate intention, it doesn't happen. I mean, one of the things that public health does is it does measure things. And so we always advise people that if you want your health equity stuff in there, you got to figure out how you're going to measure it, because that's one of the things that public health does. We had a conversation last year, and I wanted to put that in here, of how do we start talking with folks that are uncomfortable about some of these health equity pieces. If folks haven't talked about it, talking about it the first time in a professional setting can be really hard. And you all identified some four things to start that conversation, which is sharing some data, some compelling stories, looking at a shared vision, core values, investing in relationships, and offering clear expectations. This is a brief one, and next session we'll go into this much more, but I do want to just spend 5 minutes here on this last example on our fourth bridge, which is joint strategies and outcomes. And, you know, with public health, there's all these great public health policies, right? Like, we all wear seatbelts, there's signs, no smoking, there's speed limits, and this, of course, is from New York. It's a no catcall zone. So I was thinking about, you know, what are the policy implications for some of this work when we start joining with other folks? And there's a brand new, well, not so brand new, maybe a couple months old, research project and video from SOPHI, and that's not SOPHI, the public health group here in the U.S., but it is a European group that has come together, and this one I think is based actually in Italy. Has anyone seen this YouTube video? And maybe you could raise your hand if you've seen it. Ashley used it in her health psychology class. Thank you. Sent it over there. Hey, Ashley, why did you decide to use it? Maybe you can give us a synopsis of why you found it helpful, and then I'll talk a little bit about it.
Well, in health psychology, I really incorporate a strong primary prevention focus. I often have to add that because I find that I teach a basic psychology class, and I find it's very individually focused. So I'm always adding in considerations about the community and about things like social determinants of health. And so it was a really great way to not only take a previous lesson that we had about gender and everything that goes along with that, but to then link it to the idea of well-being and outcomes, and then what that means for communities and countries. And my class just, they really, really got into it, and they kept thinking, oh, wow, okay, so what it shows, which you know we're not showing you, but there are all these consequences that come from gender in EDE, and then that really affects people's lives. It even, you know, you can see it in the economy. So it really, for them, it helped really make that, they applied it. They were able to apply these concepts that showed how it can impact their lives, and not just their lives, but the health of the communities in which they live and their friends live, etc.
Yeah, I found it to be, it's a YouTube clip. It's about 3 or 4 minutes long. We put the link in there for you. And no one raised their hands. I'm wondering if people have not used this, then, oh, you got to go watch it. It's your homework. We'll give you some homework. It's fantastic. So it does exactly what Ashley says, is it really concretizes this idea of a health issue, and it positions it with inside gender equity, but also policies that are good for all kinds of things. These are screenshots from the YouTube clip, so pardon me that they're not perfect, but it starts with this concept of gender equality and policies. This is from one of their publications. You can see the citation at the bottom, but this is how they defined these different buckets. So if you look like family policies, it's parental leave, paternity leave, voluntary sector care, child and elder care policies. And then they did an analysis of countries in Europe. And what they found, they grouped them, so northern, traditional southern, traditional central, market-oriented, and eastern. So they were actually looking at the economy and the gender policies and kind of some of the norms. And what they showed is that there were incredible inequalities in health, and they were tied to this ability to access gender equitable policy. And you know, what a dream come true, you know, in this field to be able to say, look, this is how it impacts health at the national level. They have very clear graphs. Here's another one, poor mental health from wage earners for men and women. And again, this is talking about if women and men had equitable income access. So I really encourage you to look at this tool, because I think it highlights, you know, some of those things. Let me put it back here. All these different policy options that seem a little bit further away sometimes, but are very much linked to health, and that we have that data to do that. It's an excellent bridge in thinking about those things. So let me move forward here. And when you think about who might be behind those types of policies, it could be domestic workers unions, it could be restaurant workers, and your sexual and domestic violence coalition. It's a nice bridge to other folks that are thinking about this topic. And there were some comments, and I wanted to kind of open up the line here for, there we go, for Beth, who's been waiting patiently. Beth, are you there?
Yes.
All right. So
yeah.
Beth, I wonder if you could speak to this a little bit, and I think some of this is thinking about how we talk about prevention and what that looks like to folks. And I know that you were thinking about this, that we can't just think about it as a symptom and a disease. Could you speak to that a little bit?
Yeah, what I was saying is that we seem to be like people pour money into different diseases. So say like obesity. I'm giving you an example, obesity. So people have been pouring a lot of information, a lot of money into, obesity prevention, and because of the health outcomes because of obesity, so like cancer, diabetes, heart disease. And so pulling it back to looking at the ACE study and then also looking at social determinants of health, which are looking at the big picture. This is where violent, our issues come into play, where we're looking at, sexual and intimate partner violence, stalking. If these are happening in people's lives, we know the association or the risk factors that are associated with obesity, one of them being a past history of being abused or being assaulted. I see that people just keep pouring the money into obesity prevention when we aren't like going back upstream as to why this is happening. That's my thought.
Yeah. No, and I think one of the things as kind of a summary thought for me was, and Nancy, I think I opened with you and I'm closing with you, Nancy, was that remembering that the point of our work is empowering communities to be their best selves. And, as a parent and someone who thinks a lot about parenting right now in my life, it's all about being my best self. I'm not going to be a perfect parent. That is not my goal. But to really bring my best self, and I'm always looking for environments that allow me to do that. And that's usually through partnerships. And so much of this work, and again, I'm going to paraphrase Nancy, is about is what you bring and what you know and how we put those things together with her words, respect, kindness, good humor, and working together for the long haul. And so the public health approach is, quite well aligned with that vision and that approach to prevention. And I think for me that was a real aha comment, that it's not so much that this is the only approach that works, but it is so much in alignment with the fundamental kind of key characteristics and principles, the values, so that there's a lot that can be applied there. We're going to finish today with, we'll get to this one in the next session. There's an Audre Lorde quote that I couldn't find for you, but the quote that I really wanted to share was one about allies, and that when we start kind of working across approaches and sectors, one of the challenges is as an ally, you can always drop hands and walk away because it's not your issue. And now I'm paraphrasing Audre Lorde. But I think what we've been trying to do today is say that this isn't about being an ally. This is about understanding how violence is a core health issue, and that health equity makes it a core health issue, and that it's not about being an ally. It's about understanding how violence really undermines your ability to be successful in health. And I found this quote when I was looking for the other ones, that there's no such thing as a single-issue struggle because we do not live single-issue lives. We certainly don't live in single-issue environments. And so with that, what I'd like to do is give you your homework. We have 3 sessions. We're going to be getting together again in a couple weeks. I'd love for you to be able to watch that video and let us know what you think. We'd also like to get a note from you if you'd be willing to chime in over the phone. It's so nice to hear your voices. So I'm going to go back to the 8 of you that agreed to do it today, but others of you that are on the phone, there's 37 of you. If you would be willing, we'll send you a couple of kind of topics ahead of time, and you can just respond back with just some thoughts and just jot them down, just a couple minutes. And that way we can kind of be prepped, and you could be prepped, and we could open up those phone lines and have you join us. All you need to do is send an email to lisa@preventioninstitute.org and let us know you'd be willing to chime in. And then what I see that's already happening is we'd love to know what questions you have right now. where should we go next in this conversation? I know Lauren kind of identified some things that we can kind of look at in the coming section about data. That's something we wanted to do today if there was time, but we didn't think there was. So we'll talk a little bit about public health, its love of data, and how that's a benefit and a limitation in the next time. But what else? Let's keep the text chat going for a minute, and you can let us know. You can also do that again via email to Lisa or to myself. It looks like my email's on the bottom. It's Annie@PreventionInstitute.org, or it could be Lisa, Lisa. And with that, we are going to close up right on time. I can't thank you enough. And Ashley asked a question. My assignment is before the next session, watch the YouTube. Oh, yeah, that's not a question. That's a statement. Thank you.
Yes,
hey,
it's the assignment.
Thank you all for participating. There's always a nervousness that maybe no one will come to the party, and then it's not much of a peer learning forum. So thank you all for doing that, and I look forward to going deeper and asking even harder questions next session. Deborah says she wants an office like that. That's awesome. All right. Turn it back to Ashley. Thank you.
Great.
Thanks,
yes, so thank you so much to Prevention Institute, Annie and Lisa, for guiding us through, to Alexis and Casey for the text help and assistance, I keep saying text, the tech help and assistance, and thank you all for all your participation, particularly in the text chat, as well as those of you who were willing to speak verbally. We encourage that and hope that you can see that it's a friendly and very, very great audience to be in, and that we hope that you'll be encouraged to participate via audio as well in the next session. So please do email Lisa for that. So thank you all. I always appreciate being a part of a community, watching everybody learn from each other and share. We're going to be posting materials from this session at PreventConnect.org. You are already registered for the next session, the next two sessions. The next session is June 4th, and we look forward to seeing you again online. I will leave the text chat open for just a couple more minutes if you have any other questions or thoughts about what you'd like us to cover as we move on to session 2. Thank you again, everybody.